Welcome our first two speakers from Duke University. We have Ji Young, and she's a qualitative research scientist at Duke Institute for Health and Innovation. She conducts qualitative research with various stakeholders involved in the adoption of AI in healthcare. And as you know, that's our primary focus for this event is AI. She helps develop best practice for safe, effective, and equitable use of AI. And before joining DIHI, and I don't know if you actually call it a name, but Ji Young completed her PhD in social psychology at Duke University, where she studied how people are motivated to pursue their goals. And I always think it's very interesting, on a side note, in IT, in healthcare AI and all of that, we have a lot of psychology people. So it's kind of interesting to me that those two get joined a lot. The other person speaking with Ji Young today is Alethea. And Alethea is an innovative portfolio manager at DIHI and leads the project management and implementation of externally funded projects. These projects bring together domain experts, community representatives, and academic leaders to cultivate the ecosystem that promotes safe, effective, and responsible diffusion of AI slash ML in healthcare. Her other projects use innovative data science techniques to help solve challenging clinical problems. And together with the DIHI team, she hopes to build products that use technology to create value for our patients. And that's what we're all about. Yeah, we're not displaying anything yet. I just saw a note. So I'm just giving the introductions. And Alethea is a pharmacist by training from India and completed her MBA at the, I don't know if I can say it, Alethea Fuqua School of Business at Duke University in 2019. She has worked in academic research administration for 10 years at Duke and Stanford medical schools. Before joining the DIHI, and Alethea managed clinical research operations for Duke's Department in Psychiatry and Behavioral Sciences. And her long-term goal is to leverage technology to improve patient care. So we appreciate Alethea and Ji Young joining us today. And with that being said, I am going to mute myself and turn the time over to them, and they can share their screens.
Awesome. Can people see my screen? Okay. Thank you so much for the opportunity. And as it's mentioned, today's focus for this talk is on scaling best practices to advance safe, effective, and equitable use of AI in healthcare. And I will be presenting the initial part of the talk and then hand it over to my colleague, Ji Young, over here. Okay. So the overview of today's agenda. So I will go over what our office does, Duke Institute for Health Innovations, and we call it DHI, and then go over Health AI Partnership, for which DHI is the coordinating center, where we bring together experts and AI practitioners from across the nation to help us surface best practices in AI adoption. We will talk about the 8 key decision points that came out of the Health AI Partnership work. And then we will show some examples of how we use those 8 key decision points in practice. And then Ji Young will take over and talk about the other project from Health AI Partnership, which is Health Equity Across AI Lifecycle, which is a framework that we co-developed with a group of 70 practitioners in AI in healthcare to assess equities across when implementing AI solutions in clinical practice. So learning objectives for today's talk are identify common stages and decision points that healthcare organizations navigate along the AI product lifecycle, describe the implementation of best practices throughout the AI lifecycle at Duke Health, and specify procedures and analysis that healthcare organizations can complete throughout the AI product lifecycle to assess the potential impact of a technology on health inequities. So just going a little bit high level on what DHI does. So our mission is to catalyze innovations at Duke. We catalyze transformative innovations in healthcare, health and healthcare through high impact research, leadership development, and workforce training and cultivation of community of entrepreneurship. Our approach is innovation by design. So we understand the user workflow, desired outcomes and problems, and then collaboratively work with clinicians in the front lines to develop concepts, prototypes, and iterate through and find the final solution. So this slide shows the domains of DHI where we focus our efforts. Our main domains are implementation and health delivery science. So we work with, we serve the Duke clinical care teams, and we work with them to understand their workflows and develop solutions for their needs. We work on health technology innovation, so leverage the wealth of data and understand and use that data to build innovative solutions. We have a leadership and workforce development mission. So we train the workforce and physicians as well as medical students and other workforce around innovation. And then the best practice development and dissemination. This is the most recent addition of this of the domains in DHI, which is where we collaborate with other sister organizations and other leaders in the space to understand what happens after the model is developed and put into clinical practice, and what are the best practices to do that, to use models in clinical care. So this slide describes the approach, two major approaches to innovation that DHI takes. The first one is our annual request for application process, where it's a top-down plus bottom-up approach of sourcing innovation through our community, where we work with the strategic leaders to define what the strategic objective is for the year, and then seek out proposals from the clinical frontline workers to understand what their problems are and co-develop solutions for those problems. And the second, and we'll go a little bit more deeper on the RFA approach later in this presentation. And the second approach is DHI Innovation Jam, which is similar to a Shark Tank, where we focus on commercializable innovations. And over the 6 years of Shark Tank, we've went through about 30 pitches and 12 companies have been formed. And the RFA project, we've been doing this for about 11 years, and about 90 innovation projects have been undertaken, and we've reviewed somewhere around 700 proposals. This is an example of an RFA project announcement. For example, for this year's RFA, the topic was, the theme was around generative AI and large language models. And the innovators submitted their proposals, and then we will work with a team of experts to review those proposals and select about 10 proposals that we will focus on for the year. This slide describes the spectrum of value creation for DHI. So this describes that our main goals are building technology infrastructure, research and dissemination, and education. But we're also building solutions that are agnostic to the point of care. So we build solutions for inpatient settings, we have built solutions for outpatient settings or for community settings as well. And we have a lot of focus on education and workforce development as well. So now let's go a little bit deeper into health AI partnership. So to develop the best practice, so the last pillar of DHI, to develop the best practice for AI adoption, what we did was we convened stakeholders from across the nation to form Health AI Partnership. We now have about 20 corp sites and ecosystem partners who are part of this partnership, who we leverage their experience and their practices to understand the standards of AI use in healthcare. And we'll go a little bit deeper into those standards as we move forward. So for Health AI Partnership, Our mission is to empowering healthcare professionals to use AI effectively, safely, and equitably through community-informed, up-to-date standards. And we focus on these 4 values. We focus on advancing health equity. We make sure we improve patient care. So that what that means is ensure that AI adoption is driven by patient care and not by technical novelty. We focus on improving workplace, and this is very important to us, where we not only try to understand what problems could be solved by AI and is fit for solving by AI, but we go further on to understand what are socio-technical challenges when you adopt and integrate a new technology into clinical setting, and bring those challenges up and help provide guidance on how to handle those situations. And then the fourth mission is around building a community to create safe space to share learnings and consult peers. So because this space is so new, everybody's grappling with similar challenges in their own setting, in their own ways. And we wanted to create a community space where leaders in the space can come together and talk about these issues. So this slide talks about what were the major milestones for the Health AI partnership. We just completed our phase 1 in August and are now ramping up the phase 2 of Health AI partnership. So for phase 1, we had 2 major product outputs. One was standards of AI solution procurement milestones, which is the 8 key decision points, where we try to understand what are some key decisions health system leaders have to make for AI adoption throughout the life cycle, starting from the problem identification to like integrating this, building the model, integrating the solution to managing once it's out in the world. And we'll go a little bit deeper on that. And then second is the health equity framework, which is the HEAL framework. And my colleague Ji Young will go deeper into the process of building that framework and what that framework is. So 8 key decision point. So the way we built this 8 key decision point was through 2 processes. One was design research, and then we conducted an extensive qualitative research. So building standards for AI adoption was composed of these 2 activities. First, we conducted design research to understand how the standards should be designed so that health system leaders would find them immediately useful in practice. So we wanted to understand what do they need. Then we conducted the design, concurrent with the design research, we conducted qualitative research to surface content for those standards. So for design research, we collaborated with IDEO.org for a 6-week design sprint. We recruited health system leaders, representatives from the partner sites, and external AI ethics experts to participate in a series of usability testing sessions. During the usability testing sessions, the participants developed a list of products and programs that they would find helpful in practice. Ultimately, they created a simple design prototype for AI adoption standards. The prototype was structured around mock key decision points that align with how organizational leaders approach technology adoption. This design prototype provided scaffolding for our team to build upon more rigorous and comprehensive qualitative research. So for qualitative research, we conducted in-depth interviews to examine the concurrent aspirational state of AI adoption in healthcare organizations. Well, for that, we interviewed 89 professionals in healthcare and other relevant fields from our partner sites. 89 of the 89 participants, 70 were from the partner sites with clinical, technical, operational, and regulatory roles, and 19 were key informants with primary affiliation outside the healthcare organization. For the interviews, we created an interview guide and asked participants about processes and personnel involved in 4 distinct stages of AI adoption, from problem identification to life cycle management. All interviews were then transcribed and organized through 2 cycles of coding process. After the second coding cycle, we organized the most prevalent themes using the key decision point framework that was created from the design research. So this was the result of the qualitative research. Major themes were grouped into 8 key decision points across 4 stages of AI adoption. The results identified real-world processes and practices that organizations experience in adopting AI. So these key decision points were across problem identification and procurement phase, development and adoption, clinical integration, and lifecycle management. For the next set of slides, I will go through each of these 8 key decision points and give quick examples of how we use them when building an AI product. So decision point 1, identify and prioritize a problem. This decision point features guides for identifying and prioritizing problem within healthcare delivery organization and surfacing stakeholders affected by problems. Also includes guides for determining different dimensions of the problem and assessing the suitability of AI as technical approach to address problems. So for example, when I was speaking about the RFA process, that's one way of surfacing problems across the organization. So what we do is we work with the C-suite executives to identify what is the strategic priority, then come up with a theme for the request for proposals for the year and publicize that RFA proposal along with partnering with clinical and operational leaders, and then ask frontline staff to submit proposals. Then these proposals are evaluated by a set of experts, and then about 10 proposals are selected for the year. And then we work collaboratively with those frontline clinicians who've submitted these proposals to develop solutions that are suited for the problems that they're facing on the ground. Decision point 2, identify requirements for an AI product as a viable component of the solution. This decision point features guides for how an organization can assess the feasibility and viability of adopting AI to solve problems. Also include guides for conducting preliminary assessments of AI products, assessing legal risks of AI adoption, and auditing the process by which AI product investments are made. This is one example is conducting comprehensive data QA during this stage. So this becomes the bulk of the work when we are building AI models. So this is an example of the process that we use to conduct data QA, which has 4 distinct stages. The first is clinical project leader identify relevant data elements to include in the model. And this can be done through surveys or through clinician interviews or through literature review. Then for the next phase, we try to identify data elements pre-processing phase, where we try to do entity resolution, which means that group similar concepts together, and then we conduct extensive data QA checks, which is where data scientists and clinicians looks at each individual data element that is selected to be included in the model and do conformance, completeness, and plausibility checks for those elements. And then we do clinical adjudications, which means we work with the clinical champion to ensure that the data checks that are done is all accurate and are good to be included in the model. For example, this is just an example what we mean by grouping similar concepts together. So for example, creatinine in any health system data can show up under many different labels. So we look at all the ways that creatinine is coded in the electronic health record and group them together in similar concept and under one label so that they could be all included in the model. Decision point 3, develop measures of outcomes and success of the AI product. This decision point features guides for defining the scope of use, constraints, and dependencies of AI products. Also includes guides for defining technical performance targets for AI products, as well as measures of success for AI products used in practice. This, for example, are the types of metrics that we build for different phases of AI development. So we have metrics around model performance, software performance, clinical effectiveness, usability, safety, and security and business. For model performance, we will look at sensitivity, specificity, precision, those kind of things. For software performance, we'll look at throughput time, inference time, model latency, things like that. We will try to understand more clinical effectiveness, which is like if a model is trying to predict mortality, then understand mortality rate, intensive care unit requirements, things like that. For usability, we try to work with our UI designers to understand the clinical and interview our clinical staff to understand clinical satisfaction with whatever the model and its workflow is showing, user error, things like that. Safety and security, I try to understand the number of identified safety risk and mitigation, adherence to cybersecurity, things like that, data protection. And for business objectives, we try to understand, like, are we meeting the strategic objectives for time saved, cost savings, things on that metrics. This, for example, shows how we look at different model performance and try to understand for different use cases what thresholding to be is needed to be used at, and what are different measures that can show model performance like AUC, sensitivity, PPV. And we will build these type of tables and graphs for each of the projects that we do and work with our clinical experts to identify what is the best model to be used. For decision point 4, design a new optimal workflow to facilitate integration. This decision point features guides for how organizations design and test optimal workflow for clinical-facing AI products. Also include guides for adapting pre-existing operational structures, workflows, and techniques to enable successful integration of AI products. So, for example, how do we adopt workflows, roles, and organizations to solve problems? So we do not assume that the existing workflow will somehow work for once we have the AI and the user interface in place and start to integrate the solution in clinical practice. For example, for our sepsis watch model, for initial rollout, we established a role of rapid response nurse in taking the lead and managing any notifications that were shown on the sepsis watch dashboard. And this was for integrating the model at Duke University Hospital in 2018. But when we expanded the sepsis watch to Duke Raleigh Hospital in 2019, in the ED setting, the same workflow did not work because our RT nurses did not have jurisdiction in the ED department. So we needed to modify the workflow so that it would work for that particular setting. So we then started training ED charge nurses to use the sepsis watch, look at the sepsis watch notification, the sepsis watch dashboard, and then manage that workflow. And further, when we applied the same model at Duke Raleigh Hospital in the inpatient unit, their needs were completely different. So they did not want to use a dashboard rather than a notification system. So we built a push strategy where we sent them through a secure portal notifications for any time a patient meets sepsis. And then those charge nurses were then trained to follow the sepsis watch workflow. The next decision point 5, focuses on evaluate safety, effectiveness, and equity concerns of AI products in the intended setting prior to clinical use. So this decision point features guides for locally validating AI products before clinical use and identifying foreseeable and unresolved risk resulting from AI use in clinical care. Also includes guides for determining if AI products should be clinically integrated or abandoned. So one example for this was when we when we were building pediatric sepsis prediction model. So the outcome for this definition for this model was to include blood culture, antibiotics, and for 4 days and acute organ dysfunction. The model that was built had a 6-hour prediction window and a 3-hour snooze time. The model was trained on a 4-year data from 2016 to 2020 on about 17,000 encounters. And then the model was retrospectively validated on an 18-month data set on about 6,500 encounters. So this was the performance of the model that we saw on retrospective data set and temporal validation data set. And it looked promising. So we decided to go ahead and plug in the model in real-time data pipeline and conduct silent trial. Silent trial means we tested the model in real-world setting on prospective data, but without actually impacting patient care decisions during the trial. So we did not show the notifications to the clinicians, but just validated whether we are getting correct notifications or not. When we ran the silent trials for 2 months, we were expecting about 2 alarms per day for sepsis, meeting sepsis. That was consistent with like what we were seeing in the retrospective data. What we noticed was the model was firing about 30 alarms per day, which was way more than we expected from the retrospective and temporal validation. So then we had to investigate on why this was happening. And that involved working with our data science and statisticians to figure out why was the sepsis was firing 30 alarms per day rather than 2 that we were initially expecting. What we found was it was due to label leakage. The model was seeing an artifact that artificially inflated the model performance during the training due to the process called as layer normalization. When we removed the layer normalization, the model performance got actually significantly poor, which is why then we decided not to actually deploy the model in clinical use. This is an example of why it's important to validate the model in clinical real-world settings before it's getting used in clinical care. So decision point 6. This decision point is on execute AI product rollout, workflow integration, communication, education, and scaling. This decision point features guides for disseminating information about AI products to affected clinicians and mapping changes in work environment caused by AI products put into clinical use. Also includes guides for preventing inappropriate use of AI beyond their intended scope. So this this is an example of how we make sure that we have a good rollout and we can monitor the AI products after they're in the clinical practice. So we build modular infrastructure to support many projects and flexible data pipeline technology infrastructure. So healthcare data is dynamic and changes frequently over time. What we learned over time is to ensure that models are still relevant, we might need to modify the models from time to time, or modify the inputs that go into model from time to time. Like groupers might change, the concepts might change. So we learned that we needed to invest and build a modular data infrastructure that we could easily plug the models into and test and validate and run on real world setting. We also built artifacts like model fact labels that mirror design of nutrition labels to help communicate. What do these models do? What are the data inputs in it? What is the intended scope? And the target audience for this are clinicians in the frontline who will be seeing the results of these models and making decisions based on that. And these artifacts are now becoming policy from places like ONC. The 7th decision point focuses on after operationalization, monitoring and maintain the AI product and work environment. monitor and maintain the AI product and work environment. This decision point features guides for monitoring AI solutions and affected work environment over time and sustaining improved outcomes achieved through AI use. Also includes guides for conducting audits of AI products that complement ongoing monitoring and proactively identifying risks not envisioned at the time of clinical integration. So this is an example of what is involved in model monitoring. So, or monitoring the whole solution actually. So model plus the solution. So we have to conduct continuous model monitoring where we monitor the data quality, where we monitor like any drifts in data, performance of the model, etc. We also monitor the solution, which is like where we understand the workflow changes that have been made and are they still working. We understand the usage monitoring of like any user interface that we create to show the results of the model. We conduct user feedback surveys. And the operational monitoring, which means like understanding model runtimes, are the technological infrastructure that are in place sufficient to help support the model and its solution. And the last decision point, which talks about update or decommission the AI product and work environment. This decision point features guides for updating, decommissioning AI products, adapting workforce environment affected by AI use, and expanding the use of AI products in new setting. Also include guides for minimizing disruptions and harms that result from decommissioning AI products and disseminating information about AI products updates to affected clinicians. So this mainly involves what happens when we manage the AI lifecycle after the clinical integration. And what we've noticed in our experiences, there are several types of lifecycle management activities you have to do on a daily basis, on a regular cadence, and some ad hoc activities. So there are event-based activities where something comes up and it comes through the chain of communication and you fix those. There are some recurring activities, like you have to make sure that you monitor the model performance on a regular basis, make sure that you monitor all the data elements that go through, do they need any grouper or updates on a regular basis. And then there's semi-recurring solutions, which is where you try to improve the UI, or when you expand the solution into different settings, like what are some of the different things that you have to adapt. And then one-off, which is when there's some particular types of needs that are coming through end users, like how do you adapt them? That's, for example, like we don't want to see a pull notification or a dashboard. Can you send us a push notification or a direct message or things like that? So from here, I'll give it over to my colleague Ji Young, who will talk about the health equity across AI lifecycle framework, and we will take questions at the end of these presentations. Thank you.
All right. Okay. Right. All right, so from our initial work of building standards for AI adoption, in addition to surfacing best practices of AI adoption, we were able to identify challenges and risks that health systems experience. One of the common challenges that our interviews revealed was that health systems find it challenging to identify and objectively measure the potential impact of an AI product on health inequities. So even though we interviewed 13 AI ethics and bias experts, we were not able to reach a consensus on the best approaches to assess AI solutions for potential impacts on health inequities. So to close this gap, we decided to build an equity assessment framework that is grounded on real-world examples and contexts so that health system leaders can adopt it and use it in practice. Our goal was to build a framework that answers this question. Our health system is considering adopting a new solution that uses AI. How do we assess the potential future impact on health inequities? To build the framework, we adopted a double diamond design process and co-designed the framework with various stakeholders through 2 rounds of divergent and convergent thinking process. During this discover phase, we explored the problem widely by speaking to participants and documenting their responses. Then during the define phase, we synthesized collected responses. Then during the develop phase, we developed and tested prototypes. Then during the last deliver phase, we refined the final prototype and prepared for dissemination of the framework. So I'll start going over each of these phases. So for the first phase, which is the discover phase, to surface experiences of various stakeholders from healthcare organizations and ecosystem partners, we recruited 77 professionals with clinical, technical, operational, regulatory, and AI ethics expertise and hosted a workshop. The workshop featured 2 different case studies. During the workshop, each case study team presented their case. The rest of the workshop participants had discussion around the questions related to health equity derived from each case and shared their diverse perspectives. Before going further into describing the co-design process, I want to give you a breakdown of 77 participants and descriptions of their involvement. Among the 77 participants, we had 6 framework developers who are clinician, community representative, computer scientist, project manager, legal expert, and socio-technical scholar. They helped creating a scaffolding of the framework and contributed to developing its content. We then had health tech partnership leaders consisting of clinicians, computer scientists, lawyer, and community organizer whose expertise complemented the framework developers. They evaluated the framework and provided feedback. We had a team of design researchers at DHI who facilitated the co-design process by collecting, iterating, and synthesizing data from all participants. So in the next set of slides, as I show you the next phases of the design process, you'll be able to see how different participants described here were engaged in the process. So during the next phase, which is the define phase, key insights from the workshops were synthesized and categorized into different domains of assessment that the framework developers identified. During the development phase, prototypes of the framework were developed and tested twice. The first prototype contained 6 assessment domains and procedures for assessing each domain. The prototype was tested by a DHI case study team. The case study team reported some inconvenience related to the structure of the framework. What they said is they said that they proposed structuring the framework around 8 key decision points so that all procedures can flow sequentially across the entire AI lifecycle. So based on their feedback, design researchers distributed these 6 assessment domains across 8 key decision points and generated the second prototype. The second prototype was tested by a DI case study team again and reviewed by health IT partnership leaders and framework developers. The case study team reported that they were satisfied with the new structure of the framework and offered clarification on some of procedures. In parallel, health IT partnership leaders and framework developers reviewed the framework and provided further feedback. So here's the last stage, which is the deliver phase. So design researchers incorporated all of the feedback gathered from different sources from earlier phases and refined the second prototype. So the HEAL framework is currently under review for publication and will be accessible to everyone. So the 4 phases of design process resulted in creating the health equity across AI lifecycle framework. This HEAL framework is structured around 8 key decision points of AI adoption, and it assesses the impact of AI on health inequity through a comprehensive list of step-by-step procedures. The strength of this framework is that it is a community-generated framework based on real-world examples. So the framework assesses health equity concerns in 5 different domains: accountability, fairness, fitness for purpose, reliability and validity, and transparency. Each key decision point indicates which assessment domains are being evaluated. So I want to quickly point out that initially the framework prototype contained 6 assessment domains with policy and regulation as an additional domain. But during the development phase, Health IT partnership leaders with regulatory expertise suggested that engaging regulatory stakeholders in a few procedures was not sufficient to assess the policy and regulation domain. And they also said that no single set of procedures could be applied to diverse AI use cases given the dynamic nature of regulation. So the policy and regulation assessment domain was excluded from the framework, resulting in these 5 different assessment domains. So the framework contains detailed step-by-step procedures that are tailored to an existing and a new AI solution. So in total, the framework has 37 procedures for evaluating an existing AI solution and 34 procedures for evaluating a new AI solution. Additional steps are required for evaluating an existing solution to ensure that it aligns with implementation context. The framework contains procedures that focus not only on components of the AI model, but also on the components of the implementation context. These procedures show how achieving algorithm fairness may be distinct from achieving health equity. By including procedures for the evaluating the implementation context, the framework attempts to close the potential gap between algorithm fairness and health equity. So for example, an algorithm that is fair, performing well across different subgroups may worsen health equity when it is integrated into clinical practice because availability of resources and personnel in the implementation context can influence the use of algorithm. And similarly, an algorithm that isn't fair may not always necessarily hinder health equity when it is integrated into clinical practice. So by understanding the inequities present in the algorithm and implementing proactive mitigation strategies, the algorithm can be used for promoting health equity. So the HEAL framework highlights 4 complex challenges that will require significant attention and investment by diverse stakeholders. So HEAL is applied in a context-specific manner. An AI solution that is evaluated by one setting through HEAL should be reassessed when a different setting considers implementation. And successful implementation of HEAL requires significant expertise, technology infrastructure, and personal effort. Despite the framework being publicly accessible and consensus among healthcare leaders to eliminate bias in AI, healthcare delivery organization will not be able to apply the entire framework to every AI solution without significant support. So therefore, healthcare delivery organizations that adopt HEAL should be financially incentivized. And there's concern that HEAL can serve as a rubber stamp for healthcare organizations to outwardly project commitment to equity while minimizing changes to organizational practices. So to address this, independent registries may provide transparency and traceability throughout HEAL procedures to hold healthcare organizations accountable. So 2 case studies teams from NYP and PCCI are currently planning to apply the framework to evaluate their algorithms, provide their findings, and provide additional feedback on the framework. This work will further inform us more about the usability of the framework. And we hope to continue iterating on the HEAL framework as best practices to mitigate health inequities emerge. So health systems are in need of shared standards to governing the AI adoption process. The absence of shared standards not only creates social and economic costs on individual health systems, but also impedes safe and effective AI adoption. We hope that our multi-organizational effort can help health systems make informed decisions around adopting emerging technologies. In the coming month, we hope to engage more healthcare delivery organizations to adopt and test our best practices. And we plan to continue surfacing contemporary best practices and address challenges faced by healthcare delivery organizations. So if you're interested in learning more about best practices of AI adoption, please visit our website at healthapartnership.org, and feel free to contact us if you wish to provide any feedback or participate as an organization that adopts the best practices. And we always welcome your engagement. So on that note, thank you very much for everyone for listening to us, and thank you for our funders and all our researchers to be part of this project. And thank you again for having us today to share our work. And if you have any questions, please let us know. Thank you so much.
Thank you, G and Alethea. This is really interesting. How you're trying to establish the standards for people to use. And I see we already have a question from one of the users one of the attendees wanting to know if you can share again the 6th assessment domain and the reason for not including it. Can you go into a little bit more detail on why that's not being included in the HEAL?
Yeah, so the 5 assessment domain, let me share the screen again. One moment. All right, so here are the 5 assessment domains that we surfaced. And then one of the assessment domain that we did not include it is on policy and regulation. So initially we had some procedures that contained, that engaged regulatory stakeholders. For example, those procedures were getting an IRB approval from IRB and making sure that all of the implementation and testing were ethical. And we also had some engagement of regulatory stakeholders to ensure that all of the activities are compliant to, institutional standards, things like that. However, we realized that those procedures were not sufficient to address the entire policy and regulation domain, because a set of regulation or policy may not be applicable to all health systems. And the regulations on the use of AI has been changing over time. So in order to just make sure that we do not have like a single set of procedures, we decided to take out that policy and regulation as a domain. Yep.
We can't hear you.
Wait.
Teresa, I think you're in mute.
Muted. I'm muted. That's me. I always forget that. So I was just saying, I think that answered Adeline's question. We do have another question from Erica Cox, who asked, roughly how long did it take each team to create the framework?
Alethea, do you want to talk more about it?
Yeah. So, good. Sorry, we are sitting in the same conference room, so we are having some feedback issues. Sorry, apologize about that. Yes, so for HEAL framework, we actually had the workshop in early February, and we've been planning for the workshop, figuring out what cases we will discuss in the workshop to understand health equity. So the way we designed this work, as G explained, was we wanted to use real world cases, put it in front of the team of experts and try to understand how they would solve this issue. And then from that data, we collected a lot of information from the workshop. Then we worked with the framework developer team from different types of like domains to understand how do we make sense of all this information that we've collected from these experts and try to put it in a framework that is accessible and usable by our target audience, which is like health system leaders and clinicians who are applying AI tools in clinical practice. And that whole process, I think, took us all the way until the 2 iterations, the initial testing with the DHI team, and then again, feedback and testing with the case study teams until like September or October to get it all done. So almost like more than 6-month long sprint. But I think we are still in the process of making sure that top to bottom, we will test this framework out on multiple solutions. I think the next process is to understand resource need requirements, feasibility of procedures, what can be done for what kind of solutions, things like that. Yeah. And right now it's still in the publication peer review space.
All right. Hopefully that answered Erica's question. If you have another question, you can post it in the QA or in the chat. I have a couple questions here. You know, working in data like I do, I am always concerned about data quality and how that affects, and AI is obviously using a lot of data. Have y'all had any experience where you thought you were on a good track and then, you know, found out the data quality was just not there? It was, you know, and it was misleading in some of the. I'll let y'all answer that.
I was going to say, sorry, my colleague Mark's here too. And yes, we've had several of those experiences, and I'm sure he can give you a lot of anecdotes. Like, as I was mentioning, data quality is the bulk of the work. Mark, do you want to take this?
Sure. So I'm Mark. I work with Alethea and G and have been at DHI for a long time. You'll see me in the next session. But one of my favorite examples of this was we were building a sepsis algorithm, and we needed to curate historical data to identify the sepsis outcomes of hospital admissions at Duke. And this was data from 2014 and 2015. And the time period we were looking at covered the launch of the Epic Beaker module, which is the lab system. So it's the module for the collection of all laboratory data. And the lab system transitioned in, I think it was like October of 2014. So when we pulled the data originally, our cohort started in July of 2014. And for the first few months between July and October, we weren't seeing any sepsis events. And that was because the way the data was captured prior to the Beaker system launch was obscured from us. Like the labels of blood cultures was just description. It was very vague. Like if you looked at that component name, you had no clue what the lab was. You had to go look at other descriptive data about the lab to figure out what it was. So that was an example where we ended up finding this change in the system that altered the way data was captured and the way data was collected. And we had to make the decision that for those few months, we just weren't going to use the data and kind of concatenate the cohort. So it happens all the time where you cast a wide net and then you slowly have to trim down what you think is actually usable.
Great. So thank you, Mark. We have a couple more questions or comments out here. One says, question about accountability. Sepsis example, a clinical integration number 6. It says prediction of sepsis. What if the prediction is no sepsis? How much leeway is there in that decision Definitely, probably, unlikely. What if it is unlikely and providers work from that basis, but the patient gets sepsis? Who is accountable?
Mark, do you want to take it? You're
So,
on
and
mute.
the question's in the chat if you want to read it, because that was kind of long.
Yeah, and to give context, some of these things happened years ago. So our sepsis model, we implemented, the adult sepsis model we implemented in 2018. I imagine this question is about the pediatric sepsis model, which one of the takeaways is we ended up not implementing it. So that model was not implemented, but I can speak to like bigger picture. When we do implement models, we leave a lot of autonomy for physicians to make the determinations of what the diagnosis is and what appropriate treatment is. And that's actually why we developed the model label, because we wanted to make sure that clinicians knew what the model's limitations was, what its intended use was, how not to use it. So I would say it goes both ways, where there's times that the model is wrong and we don't identify a patient who becomes septic, and the physician is still expected to kind of be making that diagnosis. And then there's other cases where the model does fire an alert. There's a conversation with the physician in the emergency department, and the physician in the emergency department disagrees, and that's totally fine.
Great. And then there's another comment from Mary Teets who says, regarding policy domain, it seems that knowing what community policies should be considered as part of the creation. Might you considering, I'm not sure if I'm reading this in the right tone, might you considering have policy formation and something like a placeholder for the domain's consideration? I don't know if I'm reading that right, but does that make sense?
I can try to answer that.
Okay.
Sorry, I can try to answer that. So if I'm understanding your question correctly, you are asking like local policies are still important, community policies are still important. We should still consider that as part when we consider health equity assessment for the projects. I think, yes, overall, yes, we have to comply with our institutional policies and regulation and ethics standards and all of that. I think the reason we removed policy domain from the equity assessment was because it's just such a wide set of like information and processing that it needs to be in its own space, rather than we could not capture it in certain set of procedures that could be part of a network, so of the framework. So that was the main reason we dropped it. But we definitely are also doing another project where we are trying to understand the larger regulations and frameworks that are put out at the national level, where we are trying to understand how our best practices map and meet those standards. So I think the challenge is, how do you convert those principles and policies into best practices and actionable things that prove, or that sort of like shows compliance with those. And I think it has to be out of those procedures and thought throughout the life cycle of the AI adoption and development, if that makes sense.
Yeah, she said, okay, thanks. Yes, larger impact on communities matters for AI development. We also had a question from Erica Ashley that says, what is the percentage of accuracy in the data acquired from the clinical integration of AI in the projects? What is the percentage of accuracy in the data?
I read that in the chat, and it would be helpful if Erica can kind of further describe that. I don't know if I understand what that means.
Erica, you can, if you want to unmute and give more information or type in the what you're looking for. And while she's doing that, I'm going to go on to the Sally Barlow says, were these models implemented in lieu of the Epic ML models? Or do you also have the Epic ML models implemented as well?
So there are other use cases at Duke for which we use models, whether they be from Epic or other vendors. I would say most of the examples here were internally built, but not, we also implement models, I should make clear, we also implement models from other sources. So it's a mix at Duke.
Okay. Going back to Erica, did you, I'm asking her to unmute if she wants to,
Can you hear me?
yeah, now I can. Mhm.
Okay, so I didn't want to interrupt as he was talking and you were talking. So going back to clinical example, like number 6 with the prediction of sepsis, how accurate were the results based off of the AI integration?
Like how often was it right?
Yes.
Yeah. So part of the complexity of answering that question is that for each model, there's like different measures of performance, and every model performs differently. So one example from our portfolio last year, we were working on lung transplant, and Duke is a big lung transplant site. There was a desire from some pulmonologists to be able to better understand risk of complications after lung transplant. We did curate all the data that we could. Our cohort over multiple years was like 700, 800 patients, and we could not build a model that performed well enough for our clinicians to want to use it. Like, that's an example where you may pick certain problems to work on where like you can't actually do the modeling task well. There's other examples where you can do the modeling task well. Different measures that we look at are sensitivity, specificity, positive predictive value, number needed to evaluate. So like the number of alerts you need to look at. I would say now I'm just like very high level. If a number needed to evaluate is greater than 10, so like you need to look at 10 alerts to get one that's going to go on to develop the outcome, that starts to get concerning. But we've worked on use cases like HIV that are extremely low prevalence events where you're willing to put 10 people on pre-exposure prophylaxis to avoid one infection. So there's not a good single answer for like the level of accuracy to look for, but it requires a lot of collaboration with clinical partners. Was that helpful, Erica?
It does. Thank you so much.
All right. Well, then I had one other question for G and Lalithia, and I just wondered, did you have in all these AI projects that you have going on, and it seems like you have a lot going on that you're, trying to develop and work on. Is there a favorite project where you went, wow, this is really going to be impactful and make a difference in patients' outcomes that you've really like felt really great about, and why?
Okay. honestly recently joined DHI. It was not too long ago, but the first project that I was involved in was surfacing the best practices of AI use. So that's the eight key decision points that Olivia described. That I found it really helpful on my personal level, because as I was new to like healthcare and AI, I was able to, from this project, I was able to learn the entire life cycle of AI and how it gets used in the clinical setting. So I really enjoy like listening to all those interviews, like analyzing the responses and putting together the framework of 8 key decision points. Like, so to me, I think that was so far the favorite project that I was part of.
Great. Alethea?
Yeah. Sorry, we have now figured out what the issues. Yes, so I joined DHI with G, and I think I joined right before ChatGPT made AI a common thing across the world. So I think I really appreciated Health AI Partnership Project, where we are trying to cut through the hype and really try to understand what are the problems for which AI is a good fit, and how do we responsibly integrate it. I think I like the philosophy where we are not promoting the technology itself, but we're promoting what is best for patient care and patient outcomes. So I think that I think is a very valuable contribution, especially right now with all that hype around artificial intelligence and use of data. And I think just watching also, and I've been also involved in another very fascinating project for HIV PrEP prediction, so like prediction of HIV risk in local rural setting in Louisiana, which is very, very fascinating project where we are doing participatory ML, which is working with the community leaders and clinicians on the ground to really understand what are the risk factors and really gather the data around it and make sure the data is available for creating a model that will actually solve the problem. So seeing behind the scenes of like how complex, dynamic, and messy healthcare data is, and how we need a multidisciplinary effort to really make these projects work. And also like understand the socio-technical aspects of it, where you could build the best model in the world, but if it doesn't fit in the workflow, and if it doesn't solve the particular need of the clinicians on the ground, it's not of any good, right? So I think just understanding those practices is really, really important.
Great. I appreciate that. Well, we do have one more question out there, and that will probably be our last question before we take a quick break before the panel. And it says, to develop and deliver an AI solution to healthcare system takes a lot of groups and individuals to make it work, which y'all said. Would you be able to comment if the improvement in the outcome outweighs the efforts, or is it too early to evaluate that? Also, do all of your AI solutions delivered from the same platform, are you using the same platform, I guess, to deliver all the AI solutions? So it sounds like they're saying with all the effort, it's kind of like the return on investment. Is it too early to evaluate that? Is the outcome outweigh the efforts? So
I can speak from interview findings. Like, so it is right that building an AI solution requires a lot of effort. Even like purchasing an AI solution from a vendor, that requires a lot of effort and financial budget. But one thing that we noticed from the interviews was that it's pretty new to a lot of institutions in terms of like implementing AI in their clinical setting. So a lot of institutions have implemented their solution, but actually haven't had a chance to monitor the impact of the use yet. So I think from what we learned from the interview, it seems like it's a little bit too early to evaluate the outcome of the efforts. But I hope that we continue like monitoring the use of AI and then see whether it's actually, making a great impact on patient care. Anything else to add?
Yeah, and it asked if you're using the same
Sorry.
platform.
Our director Suresh is also on the call, and I think he would be the best to answer like how do we weigh outcome and impact versus like the effort. Yeah, for sure. Suresh,
Thank you. Thank you, everyone. Hope you can hear me.
you're on mute, I think.
Can you hear me now?
Yeah, we can hear you. We can
Right.
hear you.
Perfect. We specifically look at ROI on every single initiative that we take on. We are an innovation team. We certainly develop the solutions for a specific problem and put that into clinical practice and see whether we have the right effects, both from a clinical outcome perspective and also from an economic perspective, patient satisfaction, burden, etc. So we have a rigorous evaluation process that goes along with every single project that goes in. For example, for sepsis that was discussed in here, we did observe that our SEP1 bundle compliance, which was extremely low, it was about 22%, moved certainly significantly up from the bundle compliance reporting perspective to 78%, 68%, and continues to improve. That is one aspect of it, which is much more administrative side of things. We have our own internal cost evaluation pieces that we do, but from the clinical outcome perspective, we did notice that there was a significant drop in mortalities, anywhere between 22 to 33% among sepsis patients across our hospitals. So there is a significant impact on that particular perspective as well. Similarly, we have other AI models that we have in practice, which improve, for example, goal concordant care, which was at 2% before we started the project. Now it's significantly within a short period of about 18 months, increased up to 55%. And this has significant implications for patient satisfaction, family satisfaction. That's one aspect of it. Certainly, there's a significant drop in readmissions, unplanned readmissions as well. So there are a lot of aspects that we continuously evaluate on a project by project basis. And at the same time, this is being tracked at our leadership level as well for the overall impact that we provide to the health system.
Great, thank you. And it asked if y'all are using the same platform, but it sounds to me like y'all are using different platforms depending on what it is you're doing.
Teresa, you're absolutely right. We have a couple of platforms that we use. We have an internal platform which makes things extremely cost effective and improves the overall speed of developing, deploying, and most importantly, monitoring the outcome of the model. That's something that we have in place. We tend to be agnostic to a certain extent. At the same time, we look at the overall total cost of operations as well. So we do have multiple platforms. We have our internally developed platform, and we use Epic services that are available as well directly.
Great, thank you. Great job. Very interesting, great discussion and questions at the end. And I thank G and Alethea for joining us and kicking off this event.